Hello, my name is Dr. John Bachman. I'm the Saunders Professor of Primary Care at the Mayo Foundation in Rochester, Minnesota. I'm here to talk to you a little bit about an article that Dr. Stephen Adamson and I have prepared. It is called A Pilot Study of Providing Online Care in a Primary Care Setting. This article will be available in print in August. However, you can find an online version at the Mayo Clinic Proceedings website. Also on this site, you'll be able to go to links to be able to experience some of the things that I will be talking about. What we tried to do is find out if we could take care of our patients online. That patients would be able to send us information, our clinicians would be able to look at the materials, and then make decisions about how to take care of them. The first thing that we would require in doing this process would be to have a portal, a place where you can do your business on the web. This area on the web is where our patients could go, answer questions, send in pictures, send us documents, and then we could go and then exchange information in a secure, safe environment. The second thing then is to develop processes. Well, the first thing we had to find out is what would our patients be doing? It turned out that our patients would go online and they would enter any kind of complaint. In our article we found that of our 2,500 online visits, there were over 290 different diagnoses. The person enters the complaint and then they're asked a series of questions, yes and no questions. So the patient would go through the structured histories and then they would do some interesting things. If they wanted to, they could include pictures. As the study went on, we found more and more people were using pictures. It was interesting how easy it was for them to download the information to us. From the standpoint of the clinician, after they've gotten all this information, the clinician would go in and look at it. And we found that the most common diagnosis we made on our service was sinusitis. If you think about it, you don't need to see a patient who has sinusitis. If you go to the ICSI website, ICSI, you'll find guidelines for sinusitis, and they say you don't need to have a physical exam in order to make a diagnosis of sinusitis. Well, what other things did we do? Well, we monitored people with depression. We found that that was the number 2 complaint. 3 was back pain. There's a whole series of things that are listed in the article. But the thing that's important is, of the top 25 complaints, that made up only 54% of the things that we had. The rest were things that patients just thought they should send us. The physician then has an opportunity to set up a method of taking care of routine things. For example, sinusitis. I can sit down and I can say, all right, the sinusitis that I'm going to treat you with is with an antibiotic, amoxicillin. I'll put in that amoxicillin prescription. Then I'll find you a handout from mayoclinic.com that talks about sinusitis. I'll put in my diagnostic code, and then I will put in a note that talks to you about sinusitis. I can then save that. So every patient that comes in and uses sinusitis, I can use that as my template. This makes a tremendous savings for the clinician. At the end of the visit, I can just click a button, it goes off, the prescription goes off to the pharmacy, and everything goes very quickly. Well, what things did we learn about the speed of this? Interestingly enough, it's probably faster than if you do a phone call. You call a doctor's office, you talk to maybe the appointment person, you're referred to a nurse, the nurse may or may not be there, the nurse has to then call you back, you have a discussion, the nurse may then have to go to the clinician. Heck, it took hours and hours for this. We found in our studies, much to our surprise, that the most common time that an online visit was done was in the morning. Our clinicians were able to answer the responses by lunchtime or by the time they leave. What other things did we learn? Who did these online visits? Women. Working women. They would do it for their kids, they would do it for their spouses, and they would also do it for their elderly. What other things did we learn? We could save people from coming into the office. We figured about 40% of the time we actually saved you time. As a clinician, we also found that our insurance companies would cover this at a charge of $35. 11% of the time the patient was told, gee, I can't do this online, please come in. We would not charge the patient for that. But then I as a clinician could say, you know, I think I'm going to get an x-ray on that. Or, gee whiz, I'm going to get some lab work, so that when the patient came, I'd have the history that was all prepared by the patient, my lab, my x-rays, all there for me to see. It made myself a lot more efficient. Medicare patients, it was automatically billed to Medicare, denied, and then the Medicare patient was sent a bill. Medicaid patients, we would send a bill, and we would not collect money on that. We had 4,500 registrations, and in the 2-year period, we had 2,500 online consultations, and we billed for about 1,200 patients. People we didn't bill, well, if you brought the person in online and said, gee, you need to come in today. If a person had been just having a prescription refill and the doctor didn't have to think very much, they wouldn't charge. Every patient who did their online services had a relationship with the physician. The second thing is we were very concerned about security, so patients would come in and have to be identified in the office and be said, this is who you are, and then they signed up for it. The third thing is you had to be in the state of Minnesota. So those were some of the restrictions that we had in doing this service. Our biggest barriers were our own selves. We have to change our culture. Part of our project was that we were controlled by a lot of people here at Mayo just to make sure that we were safe. We really did not turn out all the stops on this to see how much we could do. This was just to explore the area. But some of the things that we did to sort of slow things down is we actually had pauses during our pilot where we would just stop things for a while and just reconnoiter. We also had a better product coming down the road, or we presume it's going to be a better product to do this online services. And so when that was introduced, we tapered back on our pilot. So we only just touched the surface of what patients could do. For the first time in primary care, we found something that was billable that gave value to the patient, was valuable to the physician, and also saved money for the insurance companies and the system. Here we are at the dawn of a time when we need to cut costs, improve quality, and improve access. What better thing to do than empower our patients, to allow them to contact us online, to provide us structured histories, and then provide to them outstanding care. And then the patients that need to be seen, we have more time to actually take care of the people that really have significant issues that need to be seen in the office. I think we have here the potential of something tremendous, and I believe our pilot helps point the way to something that is going to be very, very wonderful.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.